My name's Caroline. I am 34 years old. I have ulcerative colitis. I first noticed symptoms when I was 14 years old. It was blood in the toilet. It was something that I didn't necessarily want to talk about with anyone, but after it persisted, I told my mom, and as a family, we went to my doctor to figure out what could be causing it. And it was about a year later that I was diagnosed with ulcerative colitis.
My name is Jane Burns. I'm the clinical nurse specialist with the Mount Sinai Hospital Inflammatory Bowel Disease Program. My role with the team is to work with patients, so I see patients in clinic with the physicians half of the time, and the rest of the time I help develop the program for patient education, as well as organize a transition clinic with Sick Kids Hospital and urgent care clinic that we have on Friday mornings.
My condition progressed throughout high school, and I required stronger medications than what I had been taking initially. My symptoms had progressed to the point where they really weren't manageable at all, and I wasn't able to participate in any sort of daily activities, including going to school. I had to drop out of university for that entire first year. I suddenly became someone who had to cope with having chronic illness and very acute symptoms.
The education process with the newly diagnosed patient starts at the first interview, and I'm asking them a lot of questions. What supports they have at home, what supports they have at work, how they've managed their disease up to this point without any intervention from medical people. And then, just try and find out what their fears are. And I try to allay their fears in terms of the disease, the process, and let them know that we're in it as a team. They're not in this by themselves.
The medical staff were absolutely fantastic. Up until that point, I really didn't understand much about my condition or my diagnosis. So it was really at that point where I received the greatest education about the disease that I had, the medications that it required to control it, as well as the implications going forward of what life would be like.
Education is absolutely key for the patient. We know the latest research that's been done with this population or any chronic disease population is the more education you have, the more aware you are of your disease process, treatments, the better that you will be able to manage and the more positive outcome, which improves your quality of life.
When I first came to Mount Sinai, it was as a hospital admission, so I was very blessed to have the support of a large team of nurses, including advanced practice nurses. They were absolutely critical to my education about IBD, as well as for social support as well, and learning how to cope and how to live in the real world going forward. They were also very invaluable in introducing me to other patients that were currently on the ward, which was able to provide me with enormous peer support. It's wonderful to be able to talk with someone that's experienced some of the same challenges and obstacles that you may experience, as well as to hear their tips and advice on how to navigate going forward.
I want all new patients to go through our IBD Well program, which is a series of 3 sessions, which is basic information about the disease process, managing stress, and understanding nutrition and what that has to do with their disease process.
So it got to the point where I ended up being hospitalized, and I required very strong doses of medication. I originally started with Azicol, and as my symptoms progressed, I took Pentasa, as well as further medications such as corticosteroids.
The goal of therapy is remission. And, in order to achieve remission, they have to be adherent to the treatment program. And so talking about what that treatment program is, looking at the kinds of barriers that they may encounter, and really the best thing that I can do with patients is to write down that treatment program so they have a copy of it.
After coming out of the hospital and being controlled on medications, I had a gap year. I had had to drop all of my university courses. So during that year, it was a bit of time for me to reflect on how it was to have ulcerative colitis and what it meant for me, as well as going forward, how I was going to cope with the challenges of the symptoms, as well as being on medication and moving forward and how that would affect my life.
The goals have to be achievable, they have to be small, and we go from there. Each person is individualized. So it's a mutually agreed upon sort of goal setting, but the patient takes the lead.
When I first went home with the list of pills, it seemed fairly overwhelming. I had never required medication on a regular basis before, and I had never been required to take medication that would be lifelong. So it was a bit of a challenge trying to figure out how to cope with that. I take medications in the morning and at night, and I keep my medications near my bed. So that is the first thing I see when I wake up and the last thing I see when I go to bed. I also keep an extra set in my purse with me at all times, just in case there's bad weather. We live in Canada. You never know what might happen. Initially, I was taking medications every few hours, which was difficult for me. I felt that I was watching the clock all the time and that I wasn't able to go forward and live my life without thinking about it. So I made an appointment with my pharmacist, and we sat down and we reviewed the list together, and she came up with a great plan so that I could minimize the amount of times that I was taking medication.
You need to take your medication, be that by enema, suppository, or orally, infusion, whatever the treatment regimen is, and do it consistently to maintain that remission. And I think when people really understand that concept, and it takes some time to get there, that they're more able to be compliant.
I've always found that the most challenging aspect of having IBD is the unpredictability of it. So not knowing when you could have a flare-up, if it might occur in the next hour, if it might be next week, next month, next year. It makes it very difficult to plan for things in terms of work or education.
A flare is individualized to that person, so they have to understand and learn what a flare is to them. And that's one of the questions I ask. When was your last flare? What does a flare for you look like? Generally, there's always blood, bloody diarrhea, urgency, and, plus minus, you can have great fatigue. Some people don't have much. I'm going to ask them about, do they have achy joints anywhere? Knees, ankles, do they have any issues or problems with their eyes? Do they have any rashes that just appear? And that's all about the extraintestinal manifestations that can happen with ulcerative colitis. So they need to, first of all, be aware of what symptoms are happening. Could this be from my disease? Understand, if it's a couple of days, when you need to contact somebody, contact me. Can we change your treatment regimen? Or I need you to come into clinic so you can see a physician.
The initial goal would be to manage symptoms and to get past the flare. After that, the goal was really to live a perfectly normal, healthy life and be able to do everything that my peers could do, which was a fantastic promise to live towards.
People don't want to take pills when they're well, and one of the treatments for UC that's important is enemas and suppositories. And truly, patients, they're embarrassed and they don't know how, and they just don't want to do it. It can be messy, those kinds of things.
I have had to take enemas as part of my medical treatment. It is a difficult thing. It's something that it's not the route that anyone would particularly choose. However, having education about it, having your doctor or your nurse explain to you why this will be helpful for you goes a long way in making it a bit more palatable or achievable. So I did have to take enemas with various medications over the years, and I have had to take them for long periods of time as well, knowing that it was something that was going to improve the course of my disease as well as improve my symptoms.
What I teach patients about is that the enema actually reaches the area and coats the area that is ulcerative, that's inflamed. And so that's why the two treatments together work so well. When people are in flare, mid-flare, and are ill, they will do it.
My advice to someone that was asked to take enemas or suppositories as part of their health care would be to keep in mind the fact that this is something that will help control your symptoms throughout the day, that no one necessarily needs to know that this is something that you're doing, that this can be done in the privacy of your own home. And I think peer support and talking with others that have done it is a really great strategy to take. People can come up with great ideas. One girl that I know of was intent on not going to a slumber party that night because of this, and she talked it over with a group of girls. We had an IBD day that day, and by the end of it, on their own, they had come up with a great strategy for her to do this privately so that no one needed to know, and she went to the slumber party and she had a great time. So it's definitely achievable in the real world. It might take a bit of planning, but if it's something that's going to help control your symptoms throughout the day, it's definitely the best course to take. Remission is the best word as a UC patient. I'm very happy to say that I've been stable for a number of years, and to me the best part about that is predictability. I can plan my life, I can plan work, I can plan social events, I can go on trips, I can do anything that I want to do, and I don't have to worry that there's a flare coming around the corner or that my goals might be impeded or delayed by IBD.